Okay, everyone, today I'm here with Dr. Ozarkar. He is a doctor of the musculoskeletal system. Mr. Ozarkar, how are you doing today?
I'm good. How are you doing, Gautam?
Thank you for asking. I'm doing good also. So, yeah, let's get into the questions, I guess.
Sure.
What would you say are some reasons that really that made you get interested in the medical field?
Well, I had some early exposure in high school, and I took a cool class where I could get my certified nursing assistant and rotate with a bunch of doctors in the community, and it was really interesting to me. And then I had an opportunity to do something a little different in college. I got an accounting degree, and I realized that uh, that really wasn't for me. And I really liked speaking with people, and I really liked, uh, engaging people in different ways and being able to help them with my hands and with my mind and with a lot of different ways. So I felt it was the right fit for me, and that's why I pursued the field.
Yeah, and like after you went into the medical field, you became a doctor specialized in like joint pain. What made you really go into that?
Well, so I'm a physical medicine and rehab doctor, and then I'm also subspecialized. I'm double board certified in PM&R and in pain management, and so interventional pain management.
Hmm.
What drew me to the field was that it was a little bit of everything, like I kind of spoke about earlier. Um, I wanted to be able to use my hands. I wanted to be able to use my brain. I wanted to be able to kind of integrate everything and kind of touch on all the different domains that a physician gets to touch on. So our procedure is very procedural, um, but it's not quite as procedural as maybe like a surgical uh, specialty, but about 30% of our job is doing procedures, in the office and also in an operating room in a procedure suite, and then but we also have to think a lot. A lot of doctors will refer to us especially if there is a um, neurologic or musculoskeletal issue that's not really straightforward, and between using our mind and asking questions and using diagnostic tools such as EMGs or MRIs or CT scans and other advanced imaging, um, we can and labs we can kind of help dissect out what exactly the patient's problem is. And so I like that about the field, is that we get to put our thinking cap on a lot, and we really get to dissect everything that's happening, and then hopefully treat what's happening. But even if we can't, we can help other doctors, and help them figure out exactly what's happening with the patient.
Right, right. And could you give us like an example situation where you were called in for a consultation by a doctor and you were able to give a diagnosis on it?
Well, the classic example that a PM&R pain physician, is really called in to help for is, uh, you know, when sometimes when people have a lot of back pain and it's going down into their legs, but it also feels like hip pain or knee pain. Um, that's something that we help with all the time, or neck pain versus shoulder pain and arm pain. Sometimes pain can start in the back and go all the way down the leg, and that's usually caused by either a disc and or a nerve in the low back, or a disc or and or a nerve in the neck. And if it sounds like it's nerve pain, then we kind of go in one direction and we say, all right, is it a nerve in the low back that's being affected? Is it a nerve in the lumbosacral plexus? Is it the sciatic nerve? Is it the perineal nerve? We really dissect it out, because these nerves come out of your spine, and they clump up together in a plexus. In the arm, it's the brachial plexus. In the leg, it's the lumbosacral plexus. And then they'll split off again and turn into all these peripheral nerves. And so they kind of course through the leg and the arm. And so we have to figure out, is this carpal tunnel syndrome? Is this a median nerve entrapment at the wrist, or is it a C6 radiculopathy coming from the neck? And so the way we can help with that, for example, today I did an injection on somebody who didn't know if they had carpal tunnel syndrome or if it was coming from their neck, and so we did a neck injection on her, and she woke up with complete pain relief. And it may not be the definitive treatment for her. That pain may come back. However, when she woke up and she said, "I have zero pain," and at the beginning of before the procedure, she did have that pain, in her hands. We were able to answer a very valuable question. We now know exactly where that pain is coming from, because sometimes the MRI of the neck shows that there's stuff happening, and that they'll get an EMG or a physical exam finding indicates they also have carpal tunnel syndrome or something like that. And that's exactly what happened with her. She just, everything was positive on physical exam and all the imaging and everything, but now we know for certain it's coming from her neck. And so if this I intended to treat this problem, but if it comes back, at least she's not, no one's scratching their head, and she's not going to get an unnecessary wrist surgery. She can address the problem in her neck.
Right. And like after you identify the problem, you said that you had given a neck injection to like really make sure that it is actually where the pain is coming from. So, what are other courses of treatment which you also use to relieve pain?
Well, so before we do any injections or anything like that, we will kind of counsel the patient on if it's a common musculoskeletal issue, how to help mitigate that issue by just telling them about basic things like ergonomics and basic stretches that they can do and exercises, and then referring them to our colleagues like chiropractors and physical therapists, and massage therapists, and trying to get them to feel better and learn about their body a little bit more so they can prevent the worsening of that condition. And then if all of that fails, and we do advanced imaging and other studies that indicate that the problem is coming from the neck or the wrist or whatever, and they've kind of failed all these other options, including medications, we will proceed with something like an injection.
Right. And for like when you gain all the skills, you gain them like through your med school or your residency. So, what would you say are some like differences, like some things that which you learned in med school which really didn't translate to residency, and you're kind of surprised that does this not happen?
So, something that I learned in medical school and then in residency I found out was
Yeah, it's
not the
not.
case.
Yeah, it's like yeah.
Well, I mean, in medical school, especially in the kind of didactics portion of it, where you're just taking exams, we take a full anatomy course, and it's generally early in medical school, and and it was a very tough course because there's a lot to learn in a short period of time, but when in the question vignettes, they would describe a clinical problem, and it would be an oversimplified answer. Like, we would just say, just give them steroids. They have neck pain going down their arm, just give them steroids, and or start them on celecoxib or something like that. And it's just certainly not as straightforward as that. In medical school, they kind of teach you the next best step in management, and what you realize in real life is that there are so many things that go into play with that. Sometimes the next best step in management costs the patient $10,000, and sometimes there's another not as good option that is affordable. And so there are always lots of different things to look at. And So you have to really have a partnership with your patient and really kind of figure out what their goals are and just try to fit your treatment plan to make sure that they'll actually be able to comply with what you're prescribing them and what you're asking them to do.
Right, right. And what would you say are some key skills for a person in your field of pain management need to have to be successful?
So you have to have a deep understanding of anatomy so that you can safely perform procedures. That's one of the certainly one of the more dangerous things that we do. Understanding bony anatomy so that when we do X-ray guided injections, that we know where things are and where a needle or a device can safely go, and then also using ultrasound guidance. So I think anatomy is really important. I also think that having a really strong understanding of the medications that we use, because there are a lot of very dangerous medications that we will prescribe or recommend, and so having a really deep understanding of that and how they work with other medications that the patient may be on, and also just having a good understanding of how underlying conditions uh, can change the way we need to manage that a problem. So anatomy and then deep understanding of the medications that we use.
And as you said before, you said that things are not as simple as they might seem in medical school. Along with that, after your years of experience, what are some things that really surprised you? Like the things that you didn't really learn in med school?
Well, I think probably the most surprising thing is just uh, unfortunately how kind of rotten sometimes insurance companies and uh, the and just the payer system works in this country. Some it's there's not a lot of justice in uh, the way that many insurance companies handle a problem, and it's so I feel like in medical school there is a lot more of a sense of justice, and when you're going through rotations you're shielded from the unfortunate mess that is our healthcare system in terms of how everything gets paid out and what's approved and what's considered appropriate and what's considered medically necessary. Many times the insurance companies will be reasonable, but sometimes um, some people are just completely caught in the middle of what their doctor wants to do and what they know they need and what the insurance company wants to pay for. And so it's tough to ask somebody to give everything that they have and probably everything that they'll ever earn for something that may or may not work when the insurance company says they don't think that patient needs the treatment. And so I feel like I was shielded a lot from that in medical school. We saw glimpses of it, but getting into the real, and I think that times have changed too, and I think that the healthcare system is becoming more strained, and so insurance companies are becoming more restrictive, and so I'm just I'm not seeing the justice that uh, saw in medical school, unfortunately, and I had a vision of in medical school
Right,
for
right.
the patients.
And it's kind of weird how like insurance companies can make decisions on the patients when they really don't have any much medical knowledge on a subject.
Well, and it's I mean, I think you hit the nail on the head there. If a patient is actually, if something emergent or urgent is happening and they need a workup. For example, if I had a patient one time who had an MRI in maybe January or something, and then in March their symptoms progressed significantly, and uh, so we ordered repeat imaging, and we tried to order it as quickly as possible. As soon as the patient called, we said, well, we think you need to get imaging right now. And The insurance company, of course, denied that, saying that they just had that recent imaging, and even though we spent hours on the phone with the insurance company, their policy just didn't allow for it. And so this person had to go to several ERs in the middle of a global pandemic where they didn't really want to be in an ER. They had to go to multiple ERs to be able to get that MRI and then get the correct level of care. And that person actually probably ended up costing their insurance company 20 times what they would have had to pay if they just paid for the MRI, when I insisted that it was emergent and they should do it. And it's just, it's little nuanced things like that, that sometimes the policies that the insurance companies write don't account for. And it's more common than we think. But this person could have been disabled for the rest of their life had they not taken matters into their own hands. If they just said, well, the insurance company is not going to pay for it, I'm going to sit at home and slowly become paralyzed in my legs, then we would have just had another disabled person unnecessarily in this world, who could, who is thankfully we were able to get the treatment that they needed. But stories like this happen all the time, unfortunately. And I think in pain management, we don't really deal with, life or death situations, but there are many life or death situations that are really determined by the insurance company. And if your patient has a bad outcome and the insurance company didn't pay for things, it is still your responsibility as the physician to have recommended and made ensured appropriate follow-up for that patient, even if it was the insurance company that was the major roadblock to getting them that next appropriate care step in management. So it's sometimes it's a little frustrating, but that's why you just have to always communicate with your patients and just tell them exactly what as soon as you know it, and really build that partnership with every single patient.
Yeah, that's kind of weird, like that insurance companies can have such a big effect on a person's just well-being. Because as you said, like this man could have been paralyzed, or like he couldn't walk, couldn't be walking, and that could have been very bad. But then he took it, as you say, he took it in his own hands, and he got himself the care he needed. So, how would you say, do you think insurance companies are getting better at being more lenient, or being more the fact that they allow more patients to do what they need for their care, or is going the other way due to the pandemic? They're losing money and that's why they have to insure less and less surgeries.
Yeah, no, I think it's definitely getting worse, and I think it will continue to get worse, and I think the cost of care will continue to go up. And I think that insurance companies are becoming more restrictive, and on top of that, they're putting more and more responsibility on patients. So many times, something like 40 or 50% of America has a high deductible plan, or 40 to 50% of people who have insurance, have commercial insurance, have a high deductible plan. So that means that their family would have to spend the first $6,000 or $7,000 on their own before the insurance company starts paying for their family's care. And most Americans just don't have that. And so even if you do have insurance, good commercial insurance, most people are in the situation where they really have to see exactly what they can get done, or and a lot of patients tell me, they're like, look, my kid needs ear surgery or whatever, and so I'm just gonna have to wait on my treatment for an unknown amount of time. And so it's definitely going in the wrong direction, and it's really disheartening. And I hope there is a solution to help mitigate this long term that comes soon, because it is it's a true disservice to everybody who lives in this country,
Yeah.
unless you're fabulously wealthy.
Yeah, that's true.
That you'll get everything. But
hmm And yeah, everyone should have healthcare where they don't have to go through, you don't have like a big loan to actually pay off the debts, and then they're gonna be in debt. It should be more affordable for everybody so that people can get the healthcare they need. But
absolutely.
But moving on to your responsibilities in your day-to-day life, along with keeping in mind of what the patient needs and the insurance company, what are some other responsibilities that a doctor in pain management or the musculoskeletal field has?
Um, so I do you mean like what are some other like patient care responsibilities outside of like normal clinic work or um,
That's one. Mhm.
uh, so so uh, some pain doctors will consult in the hospital, so they'll work in a hospital and they'll be consulted when a team, say the cardiothoracic surgery team or something like that needs a little bit of help managing their pain, managing a patient's pain. They want to make sure it's safe. So the inpatient setting, there are a lot of clinical responsibilities there. Um, Most of pain management is in the clinic or in the procedure suite, but yeah, there's also uh, some pain management doctors will also do addiction medicine where they will try to, especially in terms of narcotics, try to taper patients off safely. Taper patients off of narcotic medications. Most of the time, that would be pain medications, opioids in particular, and so that is unfortunately becoming a much more popular part of our field, definitely in the sense that there are a lot of, the opioid epidemic is now going the wrong direction again, and so therefore there's a large need for that.
Right. And suppose somebody is battling addiction and they come to your clinic for some pain management. Is there a different set of like medication you use specifically for them? Because again, opioids are really addicting, and there's like a big problem in this country over the opioid epidemic. So would you say there's a different kind of medication for people who are battling addiction?
Absolutely. So, and it really depends on what stage of addiction they're in. If they're, kind of in the thick of it and they're not ready to stop, but they still have, they're not ready to quit, and they're not ready to, necessarily taper down. Um, that cohort of patients, generally, these patients do have real pain and they have real pain generators, and that's kind of what kicked off their usage of these medications in the first place. But then, sometimes it just kind of takes control, and then it kind of steers you in the wrong direction. And so if you're kind of early on in the process, then then that's when you have to get families involved, and we do try to use a lot of different other types of medications. There are 7 or 8 different category of medications other than opioids that we can use to help mitigate um, pain, and then of course injections and other, kind of engaging our colleagues in physical therapy, chiropractic, those types of things, and psychology, and utilizing everybody that we can. And then the next cohort of patients are people who want to come down on medications, and so maybe switching them to a safer substance, a safer opioid. Each opioid has a different safety profile, and so we have to have deep understanding of that as well. And so just making sure they're on the safest thing possible, and so still trying to control their pain, but just switching to something that maybe doesn't give them as many highs and lows, and just keeps them a little bit more even keeled, and hopefully will cut out some of the craving portion that makes addiction sometimes so hard to deal with. And then there are the patients who, want to be off and stay off, recovering addicts. And once you're an addict, you kind of are always an addict, in the sense that you might, some people fight that battle every single day, even if they haven't had, opioids or alcohol or whatever their substance of choice is for decades. But you never want to go down the wrong path again. And so really utilizing all the different, you know oral medications and patches and injectable things and other, and engaging all the other things that we could potentially do to help mitigate that pain. So, most of these patients are very upfront with us. And addiction is tough because even the smartest, most successful people who are very accomplished and they can kind of fall into this trap. And the thing about addiction is that most people, even the most intelligent and engaging and kind of cunning person, will be able to trick everybody in their lives, but at a certain point it always catches up. And at a certain point, especially your physician who is prescribing these medications will be able to figure that out. And there are telltale signs that everybody falls into when they're on the path to addiction. And so that's I mean, we are the true gatekeepers, which is why there aren't enough pain doctors in the United States to make sure that only pain doctors prescribe chronic opioids. But that is what needs to happen, is that really we need to be the gatekeepers for that. And for chronic opioids, not for people who have a knee surgery or an abdomen surgery and get
Hmm.
pain medications to control surgical pain, but or a pain that's short lived. But yeah, for people who are taking opioids every day or very many times throughout the week, a pain physician needs to be involved because we are truly the gatekeepers, and we can kind of help figure out long-term strategies to make sure that they don't fall into or kind of take the wrong path.
Hmm. And that's true because like if there's always should be somebody guarding, like especially an opioid, that's something that's really addictive, like really harm people. A pain physician should be a part of the transaction when you're giving somebody a substance like that. And moving on to how coronavirus has affected your job, there's this thing called telehealth, where like doctors and physicians over the world, they give medical diagnosis over a tablet or phone. So, in your line of work, do you think telehealth is a valuable addition, or is it just not going to work out?
I think that it depends on what we're doing for the patient.
Hmm.
Sometimes, like that person with the neck problem and the wrist problem that we spoke about earlier, uh, she has pain in her hand, and without doing a physical exam and without seeing her in person and without, really looking at her behavior, looking at her hands, and looking, there's subtle things that we look for with when we're making these diagnoses and we're really trying to dissect things. If they have wasting in certain muscle groups in the hand or in the forearm or in the, and what their strength is. And sometimes over telehealth, it is really difficult to tease that out. And so I would say for new patients, especially new patients with a not very straightforward problem, it is, I would say, minimally helpful, because when in March and April, when we were doing when my practice was doing exclusively telehealth, I saw several, I saw a lot of new patients over telehealth, and it was very tough to, get them to do the physical exam maneuvers that I can do in a matter of seconds, and seeing it for myself and feeling it for myself, versus trying to see them over a phone. And but at the same time, we do have a large cohort of patients that we have a long-term relationship with, whether they're opioid patients or patients who have chronic back issues or neck issues, and we know them very well. And especially if they're in a high risk group, those are not patients that need to be seen. We don't need to do a extensive physical exam on them or do extensive diagnostics on them every single time we see them. Sometimes we're just checking in and we say, we did that injection 2 weeks ago. How did that help? Where did it relieve your pain? Where did it not relieve your pain? And we can still get a lot of information. So I think there's a time and place for everything, and telehealth is no different. And I think that uh, nuance once again is really key in this. But generally speaking, for new patients, I really do not like to do telehealth because I think it's a disservice to everyone.
Mm-hmm.
And I think it's very easy to miss something that may be very important. Whereas a patient that I have a good relationship with, where we're not trying to accomplish a lot of diagnostics, but we're just checking in, I think that it's a great tool.
Mm-hmm. So pretty much like when you're out with old patients that really just doing a checkup, you can just use
Yeah,
telehealth.
follow
Rather,
straight.
mm-hmm.
Exactly.
Rather if it's like a new place, and you kind of need to be there to like, really discern what's happening.
Exactly.
And in your practice, do they have any research, internships, or volunteering opportunities for high school or college students?
So I work at a couple of different practices, and yes. So at the at the private practice I work at, no, we don't have anything like that. Though we do hire scribes who are kind of young people like yourselves who and you get to learn the lingo, stuff like that, and help us in clinic and make things go a little faster in the clinic. And then I work at a kind of research heavy job in South Lake, and we do have we partner with a lab in Irving, and they do have research externships,
Mm-hmm.
and those research externs will when we're doing kind of new cutting edge procedures, like stem cell procedures and other regenerative medicine procedures, will have that lab extern come to our clinic, and we'll look at like patients, for example, bone marrow aspirate, their own stem cells. When I'm pulling that out and I'm about to re-inject that into a knee or something like that, we'll look at their stem cells, and then give the patient, send some pictures to the patient, and then we have a couple of research things that are going on, and then also we give that extern an opportunity to learn how to prepare things like platelet-rich plasma and bone marrow aspirate concentrate, and stromal cells from adipose tissue and other things that we do at that clinic. So just to kind of give them a kind of fully translation or a fully translated clinical experience from the lab to the actual clinic.
Mm-hmm. And how would you say a high school student can gain more experience in your field, other than like obviously like going and taking courses? And could you give an example, a couple of courses they could take to get more experience in this?
I think anatomy and physiology is a great way to start. Any kinesiology classes are also really, really helpful too, just understanding how the body moves,
Mm-hmm.
how all the muscles and everything involved moves together is a great way to start. Um, and then if people are interested, psychology as well as, we pain doctors, we sometimes refer to ourselves as orthopedic psychiatrists because we do get to develop a long-term relationship with a lot of patients, and so they really lean on us for things that are not necessarily medically related, but we also have to put our thinking cap on for when they have a musculoskeletal injury. So we call ourselves orthopedic psychiatrists. So another really good or another good way to kind of learn a little bit more is taking some psychology classes and really learning about the mind.
And it's always important to know that. And you were saying before how there should be more pain doctors in this country to prescribe opioids, to get really involved in that process. So, are you seeing that increase in pain doctors, or is it just declining or staying the same?
I well, so I think it's really market dependent. Overall, it's countrywide. It's very, very underserved. But I think that uh, you know, in places that you live, and in the city that you live in, the city that I live in, I think that I would say that adequately or maybe a little overserved. I think there are a lot of pain doctors in the Dallas-Fort Worth area in particular, but if you look at Texas as a whole, it's very underserved. So, and kind of in some of the more rural areas in Texas, people, primary care doctors, for example, are handling very complex pain situations that most of the time they do not want to handle, but there's nobody else for that patient to go to, and they're just trying to do their patient a service, and it's sometimes a big disservice to both the prescribing physician and the patient. And so yeah, hopefully if we can kind of diffuse out into to more rural areas, I think that would really help curb the opioid epidemic and really make sure that we truly serve as gatekeepers and make sure that only people who truly need it are on it, and only for the amount of time that they need to be on it, and then are tapered off as quickly as possible.
And yeah, those are all the questions I have for you today. Thank you for being here today. Thank you for taking your time out your day. I know you're really busy going to all the different practices and whatnot. And yeah, if you have any questions, just let me know. I'll keep my email down below. And yeah, that's